Well, hello, everyone. Thank you so much for joining us today. And we thank you so much to Alzheimer's Texas for putting on this so important symposium and for the opportunity to share my knowledge and my passion and support of those living with and caring for those with Lewy Body Dementia. To introduce myself, my name is Sarah Hyde-Williams. I am an elder care consultant and dementia educator in private practice here in the Austin area. I'm founder of Senior Living Advisors of Austin. I'm a certified Alzheimer's disease and dementia care trainer, and I currently serve the Lewy Body Dementia Association as the Central Texas area lead support group facilitator and educator. This presentation has been adapted to fit our time today from a presentation written by Pamela Corsentino. She's the Director of Support Services for the Lewy Body Dementia Association. And I give this presentation quite frequently, and when presented in its entirety, is approximately 1 to 1.5 hours in length. If you would like more information about a full-length Lewy Body Dementia seminar in your area, please contact me for a time and location. Now, COVID has changed a few things for us, but we are hoping to offer our live presentations 3 or 4 times during the year like we have done prior to COVID, probably starting in January. So do you know Lewy? Lewy body dementia is a very complex and challenging brain disorder. It's complex because it affects many parts of the brain in ways that scientists are still trying to understand more fully. And it's challenging because its many possible symptoms make it hard to do everyday tasks that once came very easily for individuals. As researchers seek better ways to treat Lewy body dementia and to ultimately find a cure for this disease, people with Lewy body dementia and their families struggle to get an accurate diagnosis, find the best treatment, and manage at home. So during this talk today, it's meant to help people with Lewy body dementia, their families and professionals learn more about the disease, resources for coping, and many different ways of being an advocate. It explains what's known about the different types of dementia, how they are diagnosed, and more importantly, it describes how to treat and manage this difficult disease process with practical advice for both people with Lewy body dementia and their caregivers. So what is Lewy body dementia? So Lewy body dementia is a disease associated with these abnormal deposits of a protein called alpha-synuclein in the brain. These deposits, called Lewy bodies, affect chemicals in the brain whose changes in turn can lead to problems with thinking, movement, behavior, and mood. It is the most misdiagnosed form of all dementias, typically misdiagnosed as either Alzheimer's disease or Parkinson's disease. It affects well over 1 million Americans. Mostly adults over the age 50. And an interesting statistic is more men oftentimes than women. It is the second most common cause of progressive neurodegenerative dementia after Alzheimer's disease. So Alzheimer's disease affects roughly 50, 60, even upwards of 80% of all dementias diagnosed. Lewy body dementia, I've seen somewhere between 5% and up to 20%. It's becoming more and more recognized and therefore more often diagnosed. So like we did say earlier, it is a progressive neurodegenerative brain disorder. It was named for Dr. Friedrich Lewy, a German neurologist in the early 1900s. An interesting fact is that in the early 1900s, approximately 1905, 1906, Dr. Alzheimer, Dr. Lewy, Dr. Pick, and Dr. Parkinson were all working on a project, a research project, to find what was eventually named Alzheimer's disease. What they were finding were these tau proteins, these tangles that were eventually diagnosed as part of Alzheimer's. But Dr. Friedrich and Dr. Lewy, Dr. Lewy and Dr. Parkinson eventually came upon this protein alpha-synuclein that caused this disease process in the brain, that depending on the difference in diagnosis based upon symptoms, whether they be movement disorder first and then the cognitive symptoms came within that 1 year time frame, was Parkinson's disease dementia. If we saw the cognitive misfunctions first, and then we saw within a rule right around that 1 year rule, the movement disorders such as tremor or rigidity in the body, then it was deemed dementia with Lewy bodies. So these Lewy bodies are made of a protein, like we said, of alpha-synuclein. In a healthy brain, alpha-synuclein plays a number of important roles in neurons or nerve cells in the brain, especially at the synapses where the brain cells communicate with each other. In Lewy body dementia, these alpha-synuclein form into clumps inside the neurons, starting in areas of the brain that control aspects of memory and movement. This process causes neurons to work less effectively and to eventually die. So the activities of certain brain chemicals are also affected. And the result is widespread damage to the specific brain regions and decline in abilities affected by these brain regions. So the specific regions in the brain that are affected, first of all, being the cerebral cortex, which controls many functions, including information processing, perception, thought, and language. The limbic cortex, which plays a major role in emotions and behavior. The hippocampal region, which is essential in forming new memories. The midbrain and basal ganglia, which are involved in movement, balance, and coordination. And the brainstem, which is greatly important in regulating sleep and maintaining alertness. So, like I said earlier, Lewy body dementia is oftentimes misdiagnosed as Alzheimer's. However, the difference between Alzheimer's and Lewy body dementia is that in Alzheimer's disease, the prominent difficulty are these difficulties in short-term memories. The brain's inability to store new information in the form of memories in that hippocampal region where the brain stores short-term memories into long-term memories. There is a gradual decline of this cognition, and the physical symptoms are more pronounced at the later stages of Alzheimer's. So with Lewy body dementia, the memory may be relatively spared at the very beginning. However, in the moderate to late stages, we do see these memory issues are more pronounced. Fluctuating cognition is a huge diagnostic criteria for Lewy body dementia. This loop of clarity or showtime per se is what we oftentimes see. It targets a different set of cognitive functions, specifically problem solving and reasoning. So reasoning is extremely difficult with these folks. These physical symptoms may be present at all stages, and other symptoms not common in Alzheimer's, such as hallucinations, most oftentimes visual, and this REM sleep disorder, and we'll get into that in just a moment. So how it might differ with Parkinson's disease is, whereas in Parkinson's disease, it always affects movement. So this midbrain and basal ganglia, movement, balance, and coordination are always affected. It may later, but not always, develop into dementia, which we call Parkinson's disease dementia. Lewy body dementia, on the other hand, always affects cognition. It will always have one or several other Lewy body symptoms at diagnosis, which is this fluctuating cognition, hallucinations, and REM sleep disorder, and may or may not show obvious Parkinsonian symptoms in early stages. So the prognosis varies widely in the disease process, whether somewhere between 2 and 20 years. That is very much like Alzheimer's disease. However, because oftentimes the diagnosis comes so much later, we'll see in a later slide how difficult oftentimes it is for these folks to find a diagnosis, whereas general wellness, other comorbidities, and quality of clinical care always affect the prognosis. The average life expectancy for folks with Lewy body dementia is somewhere between 5 and 7 years after diagnosis. A typical Lewy body dementia diagnosis is that it oftentimes requires at least 3 physicians going through, typically a primary care physician, and then a couple of other different referrals to other physicians to finally get a proper diagnosis. About half of all diagnoses take between 12 and 18 months. And quite a few of our diagnoses are actually coming from neurologists, although we do see some primary care physicians are well versed on Lewy body dementia and can spot it quite frequently, very easily, therefore give a proper diagnosis. And the majority of these folks have been misdiagnosed with something else first, like we said, typically either Alzheimer's or Parkinson's. So there are some barriers to getting a proper diagnosis. These symptoms not always present in the exact same way. There is a terminology in the dementia world. When you've seen one person with dementia, you've seen one person with dementia. So although these clumpings of diagnostic criteria are the same, not every single person will present with every single symptom in the exact same way. Reporting sometimes of all these symptoms where we as the care partner may not think that it's related or important, may not report it, and therefore our clinician doesn't always get the full picture. So patient insight, care partner insight is always incredibly important, to be open and honest with your physician when you are going in and seeking a proper diagnosis. Some clinician-related challenges is that not always are primary care physicians familiar with such a complex disease process. Sometimes individuals are not referred to a specialist, nor are they referred to the in-depth neuropsychological testing that is necessary to get a proper diagnosis. And there is a lack of a widely available biological testing. So we'll see in a later slide, so where there are some testings that can be done to get a probable diagnosis of Lewy body dementia, there's not specifically one testing that will give us a definitive diagnosis of Lewy body. So what's really quite interesting is that a definitive diagnosis of Lewy body dementia is only available upon autopsy. So where we can get a probable Lewy body, oftentimes we're beginning to see these mixed dementias, to where an individual may present most prominently with one dementia. We're finding that upon death, upon autopsy, what we are seeing that there are 2 or 3 or many different types of dementia present in the brain all at the same time, most oftentimes coexisting with Alzheimer's, although Lewy body dementia has also been found to be in combination with either vascular dementia, frontotemporal dementia, or maybe a different type of dementia altogether. So if we are to base a diagnosis of dementia with Lewy body specifically on clinical symptoms alone, cognition definitely cognition is one of those clinical symptoms. Dementia absolutely is required for this diagnosis. And dementia simply means maybe a set of signs and symptoms that indicates a decline in thinking skills that interferes with your everyday life. To whereas memory may be relatively spared in the early portions of Lewy body dementia, not so with Alzheimer's. So that is a much different disease process. So this individual may exhibit difficulties in cognitive skills, such as paying attention, reasoning, problem solving. These are all executive functioning skills. What is really quite interesting is with these folks, visuospatial concepts are really quite abstract to them. They have difficulty recognizing how objects relate in three-dimensional space to each other. Depth perception, visual difficulties, a lot of folks complaining of visual difficulties. Lots of falls happen because they lack the ability to see maybe a curb, to step up on a curb or step down from a curb. Oftentimes a lot of depth perception is happening. And then to make this clinical diagnosis, at least two of the following clinical symptoms are required to support a probable diagnosis of Lewy body dementia. We said before, cognitive fluctuations, this delirium-like unpredictable changes in thinking, attention, and alertness. Repeated visual hallucinations of either people, children, animals is what is most typical. This REM sleep disorder behavior, we'll go through that in a following slide, and it may appear many years before the dementia. So that is a really big tip-off for folks if they're exhibiting some of these REM sleep behavior disorders to get a really good sleep apnea sleep study. We also see that some Parkinsonism, specifically these slowed movements, tremors, muscle rigidity, are also clinical symptoms that are required to support a clinical diagnosis of Lewy body dementia. There are a couple of supportive symptoms that we also see: loss of smell, which is one of those early indicators, and excessive daytime sleepiness. So there are some biomarkers that we can look at when diagnosing or getting a probable diagnosis of dementia with Lewy bodies. Some physicians oftentimes rely on MRI. A SPECT, a PET scan can indicate reduction in dopamine or glucose levels, or however the white matter in the brain. They're looking at these scans very carefully to see what brain changes have occurred so that we can get maybe a probable this is what is going on. So sleep disorders, we've talked a little bit about rapid eye movement sleep, what oftentimes is called dream enactment behavior. So whereas typically the body is paralyzed during the sleep process, with these folks that are living with rapid eye movement disorder, not so. So let's imagine you are being chased by a bear, you're just about to be eaten, and during this dream state, if your brain is is normally intact, your brain will paralyze the body. So the dream is, the body is going, your brain is going, your eyes are fluctuating. However, in this disease process, the body is in this fight or flight mode. You are literally running, thrashing, kicking, screaming, all during this dream process. I hear most oftentimes from spouses that they are no longer sleeping in the same bed, maybe even in the same room with their loved one. And so this is a very difficult, but very early indicator that there could be something going on, sometimes between 15 and 20 years, and will be very important that you get a sleep study to see if there's anything else going on. Could be an early indicator. So Lewy body dementia symptoms that are movement related that would typically indicate Parkinson's disease diagnosis first would be this bradykinesia, this slow movements, this reduced spontaneous movement, rigidity of the body, typically the muscles, postural instability. We see this, what's oftentimes deemed the Lewy lean, this upper body leaning to one side or even forward, chin forward, head forward motion. And so therefore, so many repeated falls because it throws off balance and coordination. This slow shuffling gait that we oftentimes see that will throw off balance and coordination, lots of falls as well. This quick involuntary muscle jerks or twists, twitches, this resting tremor, and a decrease or change in facial expression. So one of the characteristics of dementia with Lewy bodies is this sensitivity to traditional medication. So any medication, typically your anticholinergics, I never can say that word, these anti-acetylcholine type medications and traditional antipsychotic medications may be contraindicated for these individuals. So oftentimes we see through some of these indicating behavioral or psychotic type episodes, we will see an individual taken to the emergency room. They'll be given Haldol or Zyprexa, some of these traditional antipsychotic medications. And whereas that may be helpful with a mental health disease, maybe even with Alzheimer's, they are really contraindicated for Lewy body dementia. These folks have an opposite effect with these medications and therefore can, in essence, just kind of send them through the roof. A really opposite effect of what we're trying to do. This individual's brain really reacts differently than other dementias, and specifically to these medications that can cause a severe worsening of either the movement disorder or a potentially fatal condition known as neuroleptic malignant syndrome that is quite deadly. So one of the reactions to medications that we do see is this double effect, this double-edged sword. So whereas carbidopa, levodopa can treat Parkinsonism quite effectively, it oftentimes can cause the hallucinations or the cognition to become worse. On the other hand, if we are treating the hallucinations and the cognitive symptoms, it can cause the Parkinsonism to become worse. So something to discuss with your physician if you are taking either one of these either one of these medications and you begin seeing some of these symptoms. So the autonomic nervous system, like we said, goes a little haywire. It doesn't function properly. And some of the things that we see that are connected to the autonomic nervous system is this loss of smell. That may be one of those early indicators. Difficulty regulating temperature, way too hot, way too cold, maybe fluctuating back and forth. Difficulty controlling blood pressure. So many of our folks have what's called orthostatic hypotension. They get up way too quickly from a supine position or a laying down position, from a seated position, standing up. The body cannot regulate the blood getting back to the core or to the brain of the body, and therefore we see these syncopal situations in which they black out, they faint, they fall to the ground. So lots and lots of falls. Constipation, urinary incontinence, drooling either one side or both sides of the mouth. Runny nose is very, very common. Dizziness, abnormal sweating. We see an awful lot of that. So these cognitive symptoms that we see, like we said, memory can be spared in the very early stages. However, with moderate or late stages, we do see that memory is quite affected. And in those early stages where memory is quite intact, what we do see is the lack of focus or attention, difficulty problem solving, analytical thinking, difficulty in planning, poor sequencing. So if you're not familiar with the term sequencing, there are 42 specific steps to brushing our teeth. And oftentimes we lose a step or we get those steps out of sequence. So that's what we're talking about. Can we hand an individual a toothbrush? They know what to do with it and what steps in which to do it with. Sequencing is also important if we are going down to the store, and we in a course of sequences, we know to make 2 rights and a left to get where we're going. Cognitive mapping is also quite difficult for these folks. We walk into a room, we forget why we're there, and if we can retrace our steps and get where we're going, or figure out that we went into the kitchen to get a glass of water, then absolutely our cognitive mapping is intact. But for these folks, they have a poor time of retracing those steps to get back to where they're going. Lots of disorganized speech in conversation. Visual tracking and attention, like we said, are impaired. Visual spatial concepts and perceptual abilities are greatly impaired. Verbal and motor initiation, timed task and executive tasks are all greatly impaired as well. You might see on some of these very quick tests that some of our physicians do, either primary care physicians or neurologists do in the office. MoCA score, the Montreal Cognitive Assessment, is one of my absolute favorites. They're asked to draw a clock, and that's one of the really big indicators. If they cannot draw that clock properly, could be an indicator of a greater cognitive issue. So like we said, these fluctuating cognition levels, these moments of clarity or showtime, we go into the doctor's office, we have a great conversation, they're able to recall things in quite great clarity, and we as care partners are going, oh my word, what just happened? But this happens quite frequently, between minutes, hours, days, sometimes weeks. These unexplained episodes of confusion, these loops we see of great clarity or periods of not being able to have that attention or focus that they typically have. These periods of zoning out or appearing in staring into space, oftentimes we see as well, and this excessive daytime sleepiness. One of the things I hear from care partners most often is that my loved one is having difficulty with insomnia, up 2 hours, down 2 hours, up 2 hours, down 2 hours. So whereas this happens at night, this also happens during the day. And so we see this 24/7, either sleepiness or insomnia that just kind of comes in waves and loops. So some of the behavioral or the psychiatric symptoms that we do see are the visual hallucinations. Not only do we see these hallucinations in visual form, other modalities such as auditory, olfactory, tactile, many different hallucinations can be present, although visual is the most common. Delusions, these false beliefs that a spouse is cheating on us or someone is stealing our money, very common. These mood changes such as depression, anxiety, apathy, REM sleep disorder is part of this as well. And then of course those cognitive fluctuations. So we talked a little bit about hallucinations previously. What we see not only in visual hallucinations are these other modalities of a sense of presence, some sensation that someone is looking over your shoulder. Oftentimes either a deceased relative or a pet. We hear most often from these folks. And something pass in their peripheral vision. So either people or shadows, illusions or misperceptions of actual objects, seeing a person where there may be a coat on a hanger. Very, very common. And one of the things we really want to look at are very pronounced patterns in wallpaper or even carpet. We want to watch out for that because they see these images emerge, either a dark spot or a hole in the ground is what they perceive this as, or images that actually come out of those patterns. So when we are looking either at homes or secondary settings, such as assisted living or memory care communities, we want to look at that very carefully. They do a very good job. However, some of our older properties still have these very pronounced patterns in their communities, and just something to look for. Some of these complex hallucinations that we see are, like I said, little people, children, animals. Some may have an auditory component. They speak to them. We want to make sure that those speech patterns that are happening from them are not psychiatric in nature, telling them to either harm self or others. So we want to explore that very carefully. They may or may not be frightening to the patient. There is a medication, we'll talk about medications in a moment, but there is a certain medication that can be helpful for hallucinations. It's called Nuplazid, and typically if these are not frightening, if they simply are either comforting or not frightening at all, your physician might suggest that we not go to this expensive medication. However, for those that have had very traumatizing events happen in their life, maybe a military stint, frontline action, sometimes they're reliving these PTSD events, and they can be quite frightening. So they can be auditory in nature, hearing a train coming down the tracks where you live nowhere near a train track. They can either be smell or taste or feel a bug run across their arm. Sometimes I hear, or sometimes they'll taste this odd sensation. Mashed potatoes don't taste like mashed potatoes. They taste like metal or something quite different and quite unpleasant. So some of the delusions or false beliefs that we sometimes see are misidentification of folks, spousal infidelity. We oftentimes have this paranoid thinking that someone is taking our money. We'll have some hoarding or some other psychiatric component to this. And also we see abandonment quite frequently. And so they'll stick to a care partner quite closely, in which it's oftentimes like a young child that doesn't want a parent out of their sight. We see this as well. Some of the common delusions that we see, one of the most typical ones that I see that I'll let you read down through this, but I will really highlight one that I see most oftentimes in this disease process with my clients is Capgras syndrome. Whereas spouses, children, the very familiar people in our life are thought to be identical or near identical imposters. Someone, your spouse is in your home and suddenly they are not your spouse. They are oftentimes frightening imposter that we believe that we may be harmed. And it's really important we as the care partner continue to reassure them, I am not here to do you harm. Sometimes walking out of the room for a few minutes and re-entering will re-trigger that acknowledgement of who you are, and sometimes it takes hours or days. So I'll let you read down through the rest of these, but Capgras syndrome is the most common that I see in my practice. Treating these psychotic episodes, hallucinations, anxiety. So there is kind of a step-by-step process that I'd like to walk you through. Is we want to rule out any other contributing physical ailments, go down through this mind step of metabolic syndrome, infections such as a urinary tract infection. We want to rule out any nutritional deficits, and we want to rule out any drugs that could be causing what is maybe a pseudo dementia, or could be causing a greater psychosis, hallucination, anxiety. We want to review medications that may be reduced or stopped. We want to identify any environmental or social factors that could be triggering this. First, we want to look at non-pharmacological approaches to behavior management first, rather than throw a medication at it. We want to consider as our frontline pharmacological therapy an antidepressant first. That may be a very good first step rather than an antipsychotic. And we want to be very, very conservative when we're looking or having to go that one step further to look at an atypical antipsychotic medication. And also, as we talked about earlier, the sensitivities to these medications, we want to monitor for any reactions that these folks may have. So a current treatment strategy is always, our goal is to improve quality of life. We want to manage or reduce any medications or therapies that may be helpful with these symptoms. While currently no treatments are currently available to stop Lewy body dementia disease process, whereas with Alzheimer's, we see these typical medications of Aricept, Namenda. There's a new one out on the market that is a combination of those two medications together. Those are not typically helpful with Lewy body dementia, whereas we are seeing some really good success with the Exelon patch. So might be a discussion to have with your physician. So some of the challenges that we see specifically for care partners are these cognitive abilities, motor abilities, falls over and over and over again. These autonomic nervous system type dysfunctions such as blood pressure fluctuations, this orthostatic hypotension we see an awful lot, these sleep disorders, whereas not only if they're not sleeping, we're not sleeping. So we want to make sure that good self-care, we get the care that we possibly need while we get a good night's sleep to better care for our loved one. These cognitive fluctuations that make our daily life very, very challenging. We want to look at these behavioral symptoms of hallucinations, delusions that are very prevalent even in these beginning stages. And those activities of daily living, I'll briefly mention all 5 of the recognized: dressing and grooming, transfers, bathing, grooming, and eating independently. These are greatly affected by motor and autonomic symptoms. So we want to make sure that we get us the help that we need to continue to be a good partner to our loved one. So whether that means getting family or neighbor or community support, whether or not we go one step further to bringing in some really good home care service, or providing for our loved one in a secondary setting such as assisted living, or maybe even that next step of good dementia care. So for caregivers, we want to definitely become educated on this disease process. We want to make sure that we know what medications to avoid, what community resources there are, current treatments, and any behavioral changes that we may see. We want to educate not only ourselves, but to educate others, other healthcare providers that may come in contact with our loved one. Whether our loved one sees a new physician, goes to the emergency room, we want to fully embrace your new role as an advocate and an educator and a really good advocate for our loved one during those times. The National Health Organization is very, very important on not only reducing awareness, advancing the diagnosis, promoting any scientific advances. They're doing clinical trials, all to reduce the burden on Lewy body dementia families. So there are many, many supports for you. The Lewy Body Dementia Association website, here is their email address, their toll-free number. There is a peer-to-peer support line. I will say currently in the state of Texas, because our other groups in Dallas, Houston, and San Antonio have suspended their groups during COVID, here in Central Texas, I lead these support groups. We are currently the only online support group in the state of Texas. If you'd like to join that support group, please feel free to reach out to me and I'll put you on that email distribution list. Every phone call and email that comes into the national organization that indicates it's coming from here in Texas, I take those calls. So you will eventually speak with me or you can call me directly. My information will be further in this presentation. So I'm going to skip through a lot of these other slides to go on to mention a few other things, but there are some print materials that are available online. You can go to lbda.org and download or print these materials, and you can also have them sent directly to you, or you can contact me and I can get them to you. There are some really good symptom checklists. You can fill this out, take this to your doctor and say, hey, this is what we're experiencing, so that you can kind of fast forward that diagnosis. There are lots of care briefs, good information that we have, lots of resources for professionals. If you are a professional in the area and would like to reach out to me, I'd be happy to speak with you. I have lots of resources. One particular piece of literature called Diagnosing and Managing Lewy Body Dementia, a phenomenal resource for our physicians. If you'd like to reach out to me, I can get that in your hands. We are advancing research. There's lots of clinical trials that are going on, lots of opportunities for advocacy at the federal, state, and local levels, lots of ways for fundraising events to continue research. October is a month to remember. It is our awareness month. You'll see on my Facebook page, if you'll go to Senior Living Advisors of Austin, that all during the month of October, I put out some really great little tips and tricks for families living with Lewy body dementia to bring awareness and advocacy to our cause. So here is my contact information. Please feel free to either take a screenshot, jot this down, reach out to me either by my mobile phone or by my email. I do a lot of education with families, either in person or by Zoom calls. I do lead a quarterly this presentation in a lot more detail. And I am the facilitator of all of our current online support groups. And when we get back to meeting in person, we have 4 support groups in the area: Georgetown, Central Austin, the Highland Lakes area, which is in Marble Falls, and we do have one in Kyle. Please feel free to reach out directly to Lewy Body Dementia Association. Pamela Corsentino is our Director of Support Services. Here is her direct line and her email, and then of course the corporate headquarters. A couple of other things I do want to mention for care partners is to consider safety at all times. These changes in thinking and movement can occur, which require attention to safety. Fill out this medication alert wallet card that you saw earlier. I can get that to you, or you can download off of the website. Consider subscribing to a medical alert service to keep your loved ones safe, and address any safety issues in your home concerning areas of fall, poor lighting, stairs, cluttered walkways. And then another really important issue to talk with your physician about is driving. So also want to make sure that you're planning for your future. If you're working, consult with a legal or a financial expert about planning for disability or retirement. Really consult with a good elder care or estate planning attorney. If you don't have one, please reach out to me. I can get you connected to the ones that I work with. They can update a living will, healthcare powers of attorney, or other important documents that you have. And another thing to really explore, if you have done every single thing that you can and you are looking for a secondary setting such as assisted living or dementia care, one of the biggest factors in our practice that we do is secondary setting placement. So if you'd like to explore that option, please give me a call. My initial consultations are complimentary. I'd love to chat, give education, and provide you with some resources. So once again, thank you so much for tuning in. We have maxed out our time, and so I've got to go. But once again, a shout out to Alzheimer's Texas for providing this education, not only to you, but for asking us to step in and provide this education to you. If we can be helpful at all, please reach out to us. And thank you so much for joining us. Have a great day.